So as I said, pleasure to be here and join you for the first talk of this session on U.S. healthcare reform and digital health transformation. I just want to start by saying I also have no commercial conflicts in my talk, and I receive only salary from the University of California, so the government of California. Next slide, please. Pierre, can you advance that slide? Thanks. So this is a photograph of the campus of the University of California. You can see the healthcare campus, which is right in front of you. You can see the Pacific Ocean in the distance. And to the left, a little bit difficult to see, is actually Mexico. So the University of California is in very southern California, right at the border of Mexico. Our healthcare campus has grown tremendously in the last 10 years or so. Hospital, clinical research center, cancer center, ophthalmology hospital, and a lot of other facilities. In the distance is the University of California campus in general. One of the University of California system campuses, our sisters are University of California at Los Angeles, San Francisco, Davis, Irvine, and Davis. Next slide, please. So I'm going to talk a little bit about the history of digitalization in the United States, and it really started primarily in 2008 as a response to the financial crisis in that year. And I have to say, in retrospect, the financial crisis of 2008 is going to seem tame compared to the crisis we're all undergoing right now in response to COVID-19. The difference in 2008, it seems like from 2020 to 2021, is that in 2008, there was a fairly organized plan in the United States for how to spend economic stimulus dollars relative to the healthcare system. Next slide. So one of the major investments made in 2008, and this was partially to stimulate the US economy, was something called the American Recovery and Reinvestment Act, or which is part of which was HITECH, the Health Information Technology and Economic Clinical Health Act. That had two parts to it: the CMS rule, the Centers for Medicare and Medicaid rules, and ONC, which is the Office of the National Coordinator for Electronic Health Records. Next slide. And part of that was really to spend, without going into a lot of detail, over $20 billion at the time, $21 billion was spent on a collection of spending, including training, education, but also electronic health records themselves, health information exchanges, where it was pumped into the economy with a very specific goal of increasing the amount of digitalization in the US healthcare system. Next slide. At the same time in the United States, there was a growing awareness of the gaps in quality in the US healthcare system. I think that we often pat ourselves on the back for having one of the most advanced healthcare systems in the world, but in fact, the data doesn't support that in all instances. We do have a very good healthcare system. There's a huge amount of equity disparity in the US healthcare system. And this monograph by the Institute of Medicine really was one of the first to really shine a bright light on the quality gaps and the safety gaps in the US healthcare system. This all happened around the same time in the early 2000s. Next slide. And this really sort of, this supports what the Institute of Medicine was talking about. This is a slide that shows to the left, Western Europe, Japan, basically Western countries or developed countries, and the United States, and showing that the United States was both spending way more money on healthcare and also having worse quality outcomes if you count life expectancy as a quality outcome, which I think most of us do. And so the United States was on this path of less quality and higher costs. And one could say that if our quality was extremely good, maybe the cost was worth it. But in fact, repeated studies show that that wasn't the case. Next slide. So here's the results of what happened with the money that was spent in the U.S. Healthcare system with electronic health records. The top is our physician offices, and the bottom are health systems. And you can see that by 2015, so from 2009, really, when the money started coming into the system, there was a huge increase in both physician offices and hospitals adopting and purchasing electronic health records. And I would say today, there's virtually no hospital and rarely a doctor's office that is not on some form of an electronic health record. Next. And it was really, I'm convinced it was because of the economic incentives that were put into place back in 2008, 2009. So what did that lead to? What was this complete digitalization supporting? Well, it supported a new movement, relatively new movement, about value-based healthcare. It's really value over volume of healthcare. I'm going to have another slide on that in a second. The ability to create data and big data to provide population health, so looking at the health of a whole population rather than just one patient at a time, and then it led to the universal adoption of electronic health records, as I said. It's also led to consumerism in healthcare in the United States, and this is a big deal. Quality and cost data are readily available on the internet to anybody who has internet connection. There's a huge amount of social media involved in healthcare now, and non-traditional healthcare encounters and patient experience really started to grow. And the photograph on that slide is a photograph of telemedicine on a handheld device. All of this, or none of this, would have been possible without a digitalized healthcare system. Next. So this is just one example of, this is a slide from last year showing you the healthcare systems in San Diego County, mainly our main competition, and how we all now get rated based on quality metrics and patient experience metrics that we submit to various organizations. This happens to be for patients with commercial health insurance. And you can see we're rated by stars. This is readily available to any individual who goes to the right website in California, and it's easily available through a Google search. Next. So value-based healthcare, what is it? It's really a really different way of thinking about healthcare based on value of care, which is quality of care divided by cost, rather than just based on volume of care. So without digitalization, it would be very difficult to measure the value of care, report the value of care, reimburse providers based on value of care, improve value of care by reducing costs or increasing quality, and providing healthcare services in general. So all of this sort of new wave of healthcare and the way we provide and measure healthcare would not have been possible without a digitalized health system. Next. So what does this really mean sort of on the ground in terms of a different way of looking at value-based healthcare? It means that traditionally we were based on a fee-for-service payment system, and in the reform system, it's pay for performance. So we get paid based on a risk-sharing plan, not in all cases, but in many cases, and over time, we will be going more and more into risk-sharing contracts. So rather than just get paid for every surgery we perform, we will be paid on not only the surgery we perform, but the quality and the outcome of that surgery as well. There's a focus in the old days, so traditional days, there was focus on quantity of care rather than quality of care. Now there's a huge focus on quality, defined in very specific ways. Length of stay reduction was important, and in the reform system, balancing length of stay and readmission reduction is important. In the traditional system, index admission focus, and now there's an episode of care, long-term focus, and focus on patients over a whole, not only episode of care, but really throughout their lifetime. And individual utilization and cost traditionally, and now it's based on population utilization and cost. So we know we have in the University of California system, for instance, we have about 60 or 70,000 patients in total in our population who are in a risk-sharing payment scheme. And our goal is to take care of those patients as a population and develop programs, for instance, to create registries for our diabetics and registries for our patients with heart failure and so forth, and look at ways we can take care of populations better and help organize doctors to do the same. Next slide. So I wouldn't do service to the evolution of healthcare in the United States, because I think that we are in a moment right now in the United States, especially and around the world, but I think especially in the US, where we're actually seeing evolution in front of our very eyes. And COVID-19 pandemic has really created a lot of change in the healthcare system. The one I'm able to talk about the most intimately is telemedicine. And I think Chris Longhurst and others might talk about other elements of this. But telemedicine, for instance, in the United States has made a huge leap under the circumstances of the pandemic, which is really only in the last 8 weeks or 8 or 9 or 10 weeks or so. It's very important to realize that the main motivation for the boost in telemedicine was more around policy and not technology. There hasn't been any major improvements in telemedicine technology per se. There has been in other elements in the digital world. But the main reason that telemedicine took off so quickly about 8 weeks ago is because the Centers for Medicare and Medicaid, these are federal government funded systems, whereas in the past did not actually pay for, or with a lot of restrictions, paid for telemedicine. They issued a waiver that they would pay for any telemedicine. They issued a waiver that they would pay for telephone visits. They issued a waiver saying that we could practice across state lines. In the past, in the United States, doctors need to stay within the states in which their license is issued. Now we can practice, as a California licensed doctor, I can now practice in Nevada using telemedicine. These are waivers. It's important to realize these are waivers. They're not changes to the law, but we hope that post-COVID, some of the waivers that have been issued will remain post-COVID. The other motivation was really a social set of issues, which is social distancing. So patients and doctors understand the need to find it works well. So, you know, when in the middle of March in California, when the governor of California issued an order for social distancing and basically shelter in place, patients didn't want to come to see the doctors, and frankly, doctors didn't want to see the patients in person. So all of a sudden, there was a social context where telemedicine was very well accepted. Obviously, you need to pick the right patients and the right circumstances, but I'll show you some data in just a second. For most of our patients, this worked out really, really well. So not much new technology related to telemedicine, but new and broader applications. Next slide. So this is so I also oversee the general internal medicine or primary care practice at UCSD. This is a set of bar graphs looking week by week at the adoption of telemedicine. I can tell you on March 16th, the weekend of March 16th, we trained about 150 primary care doctors how to use telemedicine. If the graph went all the way to the left into February, I can tell you that there was only one general internal medicine doctor using telemedicine in her practice. And all of a sudden, in the middle of March, we trained 150 doctors and we converted almost all visits to telemedicine. The blue line represents what we had budgeted at the beginning of the year of the number of visits we expected in our clinics. The red horizontal line shows that 100% of visit volume. The yellow horizontal line represents 75% of the visit volume. And I actually just received a slide this morning that updates this data one more week into last week. And we're already about 80% back to our visit volume. And you can see the gray in that bar is telemedicine. The yellow is telephone. And usually telephone visits take place because of usually a technical problem having patients use telemedicine. And the orange at the bottom are face-to-face visits where patients come into clinics. You can see that patients over the last several weeks have really gotten to understand and use telemedicine as have our doctors. And we're almost, if this continues on the trajectory here, we will be back to 100% visit volume actually in the next several weeks. So we're very happy with the acceptability of telemedicine and the quick uptake of that. This is all because of COVID. Next. By the way, we predict that post-COVID will probably maintain about 25 to 30% of all of our ambulatory care visits will be by telemedicine. So we've learned a lot of lessons from that. We think the implications for that are very important because it decreases our costs in terms of staffing and decreases our costs in terms of space. So, time is going to tell exactly what's going to happen, but I think we've learned a lot of lessons from that. So the story of healthcare reform in the U.S. is clearly still being written, and COVID-19 is a major catalyst for that. So it will change things, and if so, how? So how is it going to change things? Well, history will be the best decision maker of this. It's a little hard to predict at the moment, but I do predict that the U.S. will not be judged kindly on how we responded to this pandemic. Things like supply chain will be more important, at least in the short term, than technology itself. So even looking ahead, hopefully in a year from now, or even sooner, we'll have a vaccine as an example, which will be due to science and medicine and science. But it may be that the limiting factor in getting the vaccine out to people is the lack of syringes and needles available to administer the vaccine. We've certainly seen in the United States, supply chain was a major factor in limiting how rapidly we were able to test people, how sort of the bottlenecks in getting ventilators out to the proper hospitals and so forth. So technology alone won't solve some of these massive problems. Digital platform, however, helped us be with agility and how quickly we could respond to some of this, but it doesn't take the place of good policy, process, and especially leadership. Patient-centered medical home will be defined differently. In the United States, there's a big push to get all patients into what's called a medical home, or a focal point of a set of people taking care of their problems. More primary care will be delivered virtually for many patients. Many patients will be, and because many patients have just become more comfortable with telemedicine and other applications of mobile health. Unfortunately, technologically disadvantaged patients will fall behind. And we're going to need to figure out how to not let that happen. Next slide. So one of the biggest barriers we're frankly facing in the United States is what I mentioned before, is a lack of trust. And I don't think that any organization, from a small organization to a large organization to a huge government, can be successful if there's a lack of trust at the very highest level. So, there's no surprise. Our president has continuously been on a news briefing where he comes up with absolutely the most craziest non-scientifically based things. And when he, I think a week or two came out and said we should test using disinfectants like Lysol or bleach to fight the virus, there was a huge increase of thousands of people calling poison control centers in the United States to ask if it was a good idea or not. So we have really a countermeasure to science, Dr. Fauci, who you all probably are become familiar with now too, who represents science, really trying to work against a president who's, I'll just be polite and say, is not helping the issues very much. Feel free to cut and paste that slide if you want to use it. Next slide. So hopefully, what will the future bring when we maybe 5 or 10 years ago look back at this period of time? Hopefully, it's going to lead to a return in trusting government and public health. As I said before, history is going to judge the U.S. response very harshly. There'll be a return to globalization because it's clear during these times that we're all connected and we all need to work together. We all need to help each other. I think in the United States, there clearly will be a debate over insurance coverage for all. There will be a widespread adoption of telemedicine and remote monitoring, advanced patient-centered care virtually. There'll be new knowledge of viruses, prevention and treatment. New knowledge of viruses, by the way, will almost surely lead to new knowledge about treatment of other diseases like some cancers and other diseases that are thought to be virus-based. The role of the federal, at least in the United States, the role of the federal versus the state and local public health decision makers will be questioned and hopefully reorganized in a much less chaotic manner. And hopefully, the next time we meet, we will all be drinking wine rather than bleach. Next slide. So, nothing is simple in the US political system. Following the Obamacare political sort of years, this book came out, Stephen Brill's book, on basically the politics behind getting Obamacare in place. It isn't simple. It's a huge amount of politics in our system that really create a lot of trade-offs, and nobody in the end is completely happy with the way the system turns out. Hopefully, fighting a common enemy of COVID-19 is going to create less chaos, less indecision, and less divisiveness. Time will tell whether or not that really happens. So delighted to take questions now.